Chapter 33 Oxygenation. This recording is for educational purposes only. The concept of oxygenation refers to how well the cells, tissues, and organs of the body are supplied with oxygen. The concepts of respiration and ventilation are the two major processes that occur in the pulmonary system to oxygenate the blood. The pulmonary system is divided into upper airways and lower airways. Familiarize yourself with the anatomy of the pulmonary system. I wouldn't go too much into detail into it, but just obviously know that it starts with your nose, mouth, and it goes all the way into your alveoli where CO2 and O2 exchange happen. Ventilation is just, once again, movement of air into and out of the lungs. And a respiration, for our purposes, is the exchange of oxygen / carbon dioxide at the alveolar capillary cell membrane. Clicker check. Which diagnostic test would best measure a client's level of hypoxemia? I'm going to give you a minute. A. Chest X-ray. B. Pulse oximeter. C. ABG sampling. And D. Peak expiratory flow rate. Once again, you want to pay attention to would best measure a client's level of hypoxemia. I'm going to go with C, which is your ABG. The term hypoxemia means low blood oxygen level. ABG sampling is the most direct way in which the level of oxygen in the blood can be measured. As we mentioned in class, this is done by taking a sample of blood from your arteries, okay? And it's going to be the most or the best measure or the best way to measure hypoxemia or oxygen levels in the body. Factors that affect ventilation. We're going to start with rate and depth. Rate is how fast you breathe, and depth is how much your lungs expand to take in air. These processes affect oxygen and carbon dioxide levels in the blood. Lung compliance refers to the ease of lung inflation. Normally, the lungs inflate easily. Lung compliance is reduced by increased lung water, like edema, loss of surfactant, or conditions that cause elastin fibers in the lungs to be replaced with scar tissue, collagen. Lung elasticity, or elastic recoil, refers to the tendency of the elastin fibers to return to their original position away from the chest wall after being stretched. So think of stretching a rubber band, then letting it go. Alveoli that have been overstretched, as with emphysema, lose their elastic recoil over time. This loss of elasticity allows the lungs to inflate easily, but inhibits or prohibits deflation, leaving stale air trapped in the alveoli. Airway resistance is the resistance to airflow within the airways. The larger the diameter of the airway, the more easily air moves through it. So a respiration is considered external or internal. Once again, respirations for our purposes for oxygenation refers to the gas exchange or the oxygenation of blood and elimination of carbon dioxide in the lungs. External respiration, alveolar capillary gas exchange, occurs in the alveoli of the lungs. Oxygen diffuses across the alveolar capillary membrane into the blood of the pulmonary capillaries. Carbon dioxide, on the other hand, diffuses out of the blood and into the alveoli to be exhaled. Alright, internal respiration. This is what we call capillary tissue gas exchange. Occurs in the body organs and tissues. This is when oxygen diffuses from the blood through the capillary cellular membrane into the tissue cells, where it is used for metabolism. The controlling of your breathing comes from your brain, so the respiratory centers in the brainstem control breathing using feedback from chemoreceptors and lung receptors. Voluntary control from the motor cortex can override the involuntary respiratory centers, but only temporarily. This allows a person to continue breathing while doing activities such as talking, singing, swallowing, whistling, and blowing. Your chemoreceptors are located in the medulla of the brainstem, the carotid arteries, and the aorta. They detect changes in blood pH, O2, and CO2 levels and send messages back to the central respiratory center in the brainstem. In response, the respiratory center increases or decreases ventilation to maintain normal blood levels of pH, O2, CO2. Normally, the blood CO2 level provides the primary stimulus to breathe. Lung receptors. These are located in the lungs and chest wall and are sensitive to breathing patterns, lung expansion, lung compliance, airway resistance, and respiratory irritants. The respiratory center uses feedback from the lung receptors to adjust ventilation. Factors that influence pulmonary function: lifespan and development. Normal development influences lung, heart, and circulatory function, of all of which affect oxygenation. Development factors have less effect on function in young and middle adults than in older adults. You can see some of the examples in the slides, such as respiratory distress syndrome, upper respiratory infections with older people, adolescent smoking, cardiac insufficiency. Environmental. These are stress, allergic reactions, altitude, and temperature that affect oxygenation. Stress suppresses the immune system and inflammatory response. A chronically suppressed immune and inflammatory response increases the risk for all infections, including respiratory. Allergic reactions. These are pulmonary allergens, include things such as dust, dust mites, cockroaches, pollen, molds, tobacco smoke, animal dander, and sometimes foods. The altitude. Low oxygen levels at high altitudes can cause hypoxemia and hypoxia. Lifestyles, such as pregnancy, occupational exposures to hazards, nutrition, obesity, exercise, smoking, vaping, and substance abuse. And like I said, big one, smoking. So tobacco smoke pretty much constricts the bronchioles, increases fluid secretion into the airway, causes inflammation and swelling of the bronchial lining, and paralyzes the cilia. This leads to reduced airflow and increased production of secretions that are not easily removed from the airways. E-cigarettes contain nicotine, heavy metals like lead, toxic gas, and cancer-causing agents. E-cigarette use has been linked to chronic lung disease and asthma, and the combined use of e-cigarettes and traditional cigarettes is associated with cardiovascular disease. Medications. Some medications can interfere with pulmonary function by depressing respirations. Respiratory depressants generally act by depressing the central nervous system, control of breathing, or by weakening the muscles of breathing, such as with anesthesia, right? Or pain medication to some extent when you overdose somebody, or somebody overdoses, right? Okay, continuation, upper respiratory infections. So these are going to be infections of the sinuses, throat, airways, or lungs. Respiratory infections are one of the main reasons why people visit their primary care provider. The common cold is the most widespread. Respiratory infections are usually caused by viruses, but can be caused by bacteria. Upper respiratory infections. We have cold. We have rhinosinusitis, which is the inflammation of the nasal mucosa and sinus cavities. We have pharyngitis, which is like sore throat. Pharyngitis may be viral or bacterial. Strep throat, caused by Streptococcus pyogenes, is the most common cause of infections in relationship to the pharyngitis. It cannot be differentiated from viral sore throat by any one sign or symptom, so pharyngeal cultures or rapid antigen tests are conducted. Influenza. It is usually more severe than the common cold and often involves the lower airways, although some types may not. Most flu fatalities occur in children under age 2 and older adults, especially the frail elderly. Lower respiratory infections, this include acute bronchitis, pneumonia, and tuberculosis, occur more often in children, older adults, and those with impaired immunity or lung function. These examples are RSV, which can affect the upper respiratory tract in the lower airways. Healthy people usually recover from RSV infection in 1 or 2 weeks. We have acute bronchitis. It's an infection of the bronchi, causing bronchial irritation and inflammation, leading to coughing and mild airway obstruction. The bronchi become inflamed, but with no evidence of pneumonia, common cold, or asthma. Bronchitis can be viral or bacterial. Tuberculosis is the infection caused by the acid-fast bacillus Mycobacterium tuberculosis. Although TB is commonly thought as a respiratory disease, infection may occur anywhere else in the body. Okay, so continuing with factors that influence pulmonary function. So, pulmonary system abnormalities such as structural abnormalities, airway inflammation or obstruction, atelectasis, pulmonary circulation abnormalities, central nervous system abnormalities, and neuromuscular abnormalities. Socratic reasoning. A 65-year-old man with emphysema is referred to you for counseling on activities to promote better health and prevent illness. What suggestions might you make about smoking that could help him improve his health? Why would these actions be effective for this patient? Okay, I'm gonna give you pause the slide or pause the video and think about these questions. How would you answer? I'm going to go ahead and give you my answers. 1. He should be encouraged to quit smoking based on the many benefits of cessation, but efforts should be made to target the benefits most important to him. The most common motivational reasons for tobacco cessation in older adults are the prevention of cognitive impairments and increased well-being of the family. Involve family in the decision to stop smoking, for they are the ones who can help to manage quitting. Try to keep busy and focus more on hobbies and things you enjoy aside from smoking. 2. Why would these actions be effective for this patient? Well, tobacco use is the primary preventable cause of disability and death in older adults. Older people who smoke have double the mortality rate compared to the older adults who do not smoke. Improved health and decreased mortality occurs when people quit smoking, even after 65 years of age. Benefits of smoking cessation in older adults include reduced progression of respiratory disease and improvement in lung function, improved safety, quality and length of life, decreased cognitive impairment and prevention of dementia, and reduced risk of all major causes of death. Okay, so how do you assess the oxygen status of a patient? Well, you will start with the breathing pattern, such as, let's say you have tachypnea, bradypnea, euapnea, which is normal breathing, apnea or periodic breathing, Cosimal's breathing, Byatt's breathing, or Cheyne-Stokes respirations. Okay, the respiratory effort. So a patient experiencing shortness of breath or dyspnea requires a thorough assessment. Asked closed questions the patient can answer with yes, no, or only a few words. Ask whether the shortness of breath begins suddenly or gradually, how severe it is right now, and whether it is getting worse or better. Pulse oximetry. This is obviously a non-invasive estimate of the arterial blood oxygen saturation. SpO2 reflects the percentage of hemoglobin molecules carrying oxygen. The normal value is 95 to 100%. Less than 94% is considered abnormal in healthy people and should be investigated to determine the cause. And finally, using inspection, palpation, percussion, and auscultation, as you guys have learned in your health assessment class. Okay, clicker check. The term Cosimal refers to a high-pitched, harsh, crowing, inspiratory sound that occurs due to partial obstruction of the larynx. True or false? This is going to be false. The term for this sound of respiratory distress is stridor. Okay, so the continuation of or assessing oxygen status, diagnostic testing we do to obviously find out more in-depth details as to what's going on. We talked about collecting sputum samples so they can be examined microscopically and cultured in the lab to identify organisms and test for sensitivity to differentiate anti-infective agents. Tuberculin skin testing is widely used to detect exposure of any antibody formation to the tubercle bacillus. Annual screening is recommended for low-income populations and residents in congregate living conditions. Pulse oximetry, we spoke about this earlier. Capnography measures the carbon dioxide, CO2 inhaled and exhaled air. Capnography directly measures ventilation and indirectly measures the partial pressure of CO2 in the arterial blood. Spirometry is a measure of air that moves into and out of the lungs. ABGs, we spoke about this earlier, and then we also talked about peak flow monitoring in class. This is going to be for our asthma patients. These are going to be your analysis, the nursing diagnoses. Once again, we spoke about this in class, so I'm not going to go into detail. However, just write them down so that you can refer to them later for your concept map. Okay, the interventions that we want to take for optimal oxygenation. So administering respiratory medications can be interventions, right? So examples include bronchodilators, anti-inflammatory agents such as corticosteroids, cough suppressants, expectorants, and decongestants. Do not give over-the-counter cough or cold medicines to children younger than the age of 4. there is a risk for serious and even life-threatening side effects. Safety and effectiveness for children ages 5 through 11 years is still in question, by the way. The use of a mechanical ventilator. Once again, this is going to be last resort for people who do not respond to different devices such as, nasal cannula, simple mask, non-rebreather, partial non-rebreather. This is basically a machine that assists a patient to breathe. Usually the patient is intubated before they're placed on the ventilator. An endotracheal tube or tracheostomy tube is connected to the oxygen tubing to the ventilator. Before initiating ventilation, be certain that the healthcare team is aware of the advanced directives and consults with the family members. Also, the use of chest tube drainage systems. The purpose of a chest drainage system is to remove air or fluid from the pleural space without allowing it to re-enter. This is accomplished by means of a valve in the line or water seal compartment. Flow of air and fluid must be in one direction, from the patient to the collection system. So example of this could be a pneumothorax, or it could be also when fluid just builds in the lungs and it needs to be drained out. Promoting respiratory function also includes preventing healthcare-associated pneumonia. Once again, healthcare-associated is we don't want these or patients to get pneumonia while they're in the hospital, right? So obviously, send the spirometer, always washing hands when we take care of our patients. And also a big one is also recommending immunizations to prevent just respiratory diseases or upper respiratory infections. So with or people that have COPD, they are actually more prone to getting infections more than the regular person. So it is actually, we need to recommend our clients with COPD that they need to get the pneumococcal vaccine. Because once again, it is going to help them in not getting infections. These people literally, if they get an allergy or a cold, it can develop into something more serious. Obviously, if a person smokes, we got to educate them on smoking cessation. And then the positioning, we spoke about this in class, to obviously support the maximum lung excursion is going to be upright at a high Fowler's position to actually expand those lungs. The use of incentive spirometer, we spoke about the importance and how this is going to be their best friends for people who are bedbound. And then also aspiration precautions, right? So this is going to be your clients who have decreased level of consciousness or diminished gag or cough, reflex, or have difficulty swallowing. You should keep a suction set up available for routine and emergency use for these patients. Preventing aspiration requires you have practical knowledge about the positioning, enteral and oral feeds, and administering medications. The mobilizing secretions, we want to encourage deep breathing and coughing. We want to encourage hydration, right, for thinning of secretions, and chest physiotherapy. Oxygen therapy to improve oxygenation. We talked about the nasal cannulas, the mask, and transtracheal catheter. So this is going to be a catheter that is placed into the tracheostomy to deliver O2 directly into the trachea. Because oxygen cannot be humidified through this device, it is actually rarely used. Safe, effective nursing care. Question here. A nurse is teaching their client how to obtain a sputum specimen. In order to provide safe and effective care, the nurse instructs the patient that the following action will facilitate obtaining the specimen. A. Limiting fluid intake. B. Having the client take deep breaths. C. Asking the client to spit into the collection container. D. Suggestion to the client that the specimen be obtained after eating. Alright, the correct answer is going to be B. Having the client take deep breaths. To obtain a sputum specimen, the client should rinse their mouth to reduce contamination. Breathe deeply and then cough into a sputum specimen container. The client should be encouraged to cough and not to spit so as to obtain sputum. Sputum can be thinned by fluids or by a respiratory treatment such as inhalation of nebulized saline or water. The optimal time to obtain a specimen is on arising in the morning. Once again, you cannot delegate this teaching of how to collect a specimen collection to a CNA or a tech, alright? Using artificial airways. So we spoke about oropharyngeal, which is used in unconscious patients because they are likely to trigger gagging, vomiting, and laryngospasms in responsive patients with intact airway reflexes. It is C-shaped. It's hard plastic devices. They're available for infants, peds, and adult sizes. To select the appropriate size, hold the airway next to the patient's face, from the tip of the earlobe to the curvature of the mouth. Nasopharyngeal. These are going to be flexible rubber tubes that are inserted through the nostrils into the pharynx. Patients who are semi-conscious can tolerate nasal airways because they do not stimulate the gag reflex. They're also available in different sizes. ET tubes. These are pliable tubes that are inserted into the trachea through the following routes. It could be either through the oral tracheal mouth or nasal tracheal, the nose. Tracheostomy tubes are an opening actually directly into the trachea. So when somebody has a trach, that's what the tracheostomy tube is used for. Tracheostomy tubes are made of different materials. They may be cuffed or uncuffed and may have a single or double lumen. These, once again, I'm not going to go into detail. You're going to see more of this in MedSurg. So just for you guys to get an idea, overview. Okay, so to maintain patency, we need to suction. We will do this in lab, not next week, but the following week. Pharyngeal suctioning is performed to prevent oral and nasal secretions from entering the lower airway when the patient is too weak to cough up secretions. Suctioning the pharynx triggers a cough, which helps loosen and mobilize the secretions. The patient's condition determines whether you suction the pharynx through the mouth or nose. Most patients find oropharyngeal suctioning more comfortable than the nasal approach. In tracheal suctioning, a catheter is passed beyond the pharynx into the trachea to remove secretions from the lower airways. The trachea may be suctioned through the mouth, nose, or endotracheal airway. In the healthcare setting, deep tracheal suctioning is a sterile procedure. Clicker check. In caring for a client with a tracheostomy, the nurse would give priority to the nursing diagnosis of risk for ineffective airway clearance, anxiety related to suctioning, social isolation related to altered body image, or impaired tissue integrity. The answer is going to be A. While the other diagnoses may be applicable, maintaining a patent airway by tending to the excessive secretions is a priority. Okay, this is going to be all for oxygenation. Have a wonderful week. If you guys have any questions, don't hesitate to email me.